Good afternoon, everyone. Thought we would get started right on time. My name is Paul Helft. I'm the director of the Fairbanks Center for Medical Ethics. It's my pleasure to welcome you to our first lecture of the season. We do these from September through May and have been doing them for roughly 9 years or so altogether. These are open to the public, and we invite anybody and everybody to come. We try to do them once a month, alternating between the Pettigrew Auditorium here and the Riley Outpatient Center Auditorium in the basement of the Outpatient Center at Riley Hospital every other month. So welcome. So the lecture is being recorded and broadcasted today to several of our affiliate hospitals, IU Health West, Ball Memorial, North, and Arnett. We also record them for the purposes partly of archiving them on our website. So if you go to fairbankscenter.org, you can always watch them for free on our website. If you would mind silencing all your electronic devices, and if you need to answer a call or anything, if you wouldn't mind stepping out of the auditorium. I'm going to introduce Dr. Tracy Gunter in just a moment. She has no relevant conflicts of interest. Many of you know that at the Fairbanks Center we have hosted a clinical ethics fellowship, which is a year-long part-time program. We're on our 12th class of fellows, so we've done this for the past 12 years altogether, and we always take this lecture opportunity to briefly introduce to you our fellows. We usually have between 7 and 9 fellows every year who are a mix of many professional backgrounds. And I would just ask if the fellows wouldn't mind standing and to be acknowledged. You can hold your applause until all of them have been introduced. Sherry Bate, who is the Manager of Education and Respiratory Care and Pulmonary Function Tests for IU Health. Sherry. Courtney Pritchard Comer, who's a staff nurse in labor and delivery in the postpartum unit at IU Health. Courtney. Sean Gerber, who's the Director of Pastoral Care at IU Health Bloomington. Anna Kirkman, who is the Associate Counsel, Medical Legal Partnership Director at Eskenazi Health. Anna. Alex Lyon, who is a Senior Pediatric Hematology Oncology Fellow at Riley Hospital. Alex. Liam Roche, who's an Associate Partner at the Riley Hospital for Children Emergency Department. And then 2 fellows who were unable to be here with us today, Nayan Shrivastava, who's a Senior Pediatric Cardiology Fellow at Riley Hospital, and Melissa Young, who is a Pediatric Nurse Practitioner in the Department of Urology at Riley Hospital. So a very pediatric-centric group this year. But anyway, welcome to all of you, and please welcome them and congratulate them. Now, it's my great pleasure to introduce my colleague, Dr. Tracy Gunter. I've gotten to work with Tracy since she was one of our ethics fellows a couple of years ago, and get to work with her on a more weekly basis at the Indiana University Simon Cancer Center, where she sees patients partly. So Tracy is an associate professor of clinical psychiatry and an adjunct professor of law at the Indiana University School of Law as well here in Indianapolis. She graduated with an MD from the University of South Carolina. She also completed her general and forensic psychiatry training at the same institution. She did additional advanced training in research methodology at the University of Iowa, and then did our clinical ethics fellowship at the Fairbanks Center a couple of years ago. Her recent work has focused on physician suicide prevention, and in addition to that research and her many educational outreaches, she's an active clinician and a forensic mental health consultant. And it's a great pleasure to welcome her here to do this lecture, Professional Ethics and Regulation and the Problem of Physician Death by Suicide. Thank you, Tracy.
Thanks so much, Paul. It's a pleasure to work with you at the Cancer Center as well. Good afternoon. I can't tell you what a pleasure it is to be with you today. I'd like to start actually by, in addition to doing my duty about disclosures, of which there are none, my department chairman is ardently hoping I will fix that in the near future. I would like to start with my thank you slide, because I'm especially grateful to the IU Health Fairbanks Center for the mentorship provided to me during the early stages of this work. There are many others who have been important in helping me think through the issues, and some of their names appear here. In my time since finishing the Ethics Fellowship, I have presented this material at local, state, and national meetings and hope to continue to do so. I've also recently been asked to be a consultant to a credentialing committee in another state and look forward to that opportunity. What I'd like to do today is to chat a little bit with you about the problem of physician suicide. I then am taking an approach I actually have not taken before, so I await your feedback about that. I will begin then talking about self-stigma as a primary barrier to intervention and look at the ways in which ethical, regulatory, and systems issues contribute to the phenomenon of self-stigma. And then I'll end looking at interventions. Each year, an estimated 250 to 400 physicians die by suicide, leaving approximately 1 million patients each year without their doctors and leaving countless scientific discoveries unmade. Rates are generally unchanged since the late 19th century, though some claim that frequency may have increased in the last decade. Male physicians are about 1.4 times more likely than the general population to die by suicide, and female physicians are just at 2.3% more likely to die by suicide than members of the general population. Compounding this tragedy is that this has been the case for decades, if not centuries. In 1897, death by suicide accounted for 2% of all deaths in the profession, and today the estimate approximates 4% in most studies. This is compared with 2.9% of the general population. Although other professions have intermittently reported excess death by suicide, doctors have maintained this dubious distinction of dying by their own hands over the last 100 years. There are some limitations in this literature on physician death by suicide. The phenomenon is generally underreported and underappreciated. And either doctors are just accident prone, or we really are missing an opportunity here to examine all counts of preventable death by not considering that at least some accidents may be very well planned and executed suicides. In accidents and suicides, physicians are disproportionately affected compared even with other healthcare workers, others with higher education, and individuals in the general population. The notion that physicians kill themselves using the tools of their own trade is generally false. Worldwide, self-poisoning is the leading cause of death, but in the US, physicians most commonly die by gunshot wound, then self-poisoning, blunt trauma, and hanging. Combined mechanisms are at least as common as single mechanisms in physician death by suicide. Physicians are more likely than members of the general population to die in the workplace, but most, in fact, do die at home or on private property. In the general population, the lion's share of increased risk may be accounted for by mental illness, followed by relationship problems. Most suicide victims give prior warnings, and relatively speaking, job problems or legal problems are relatively small contributors compared to the others. Circumstances for physicians are a bit different. Job problems account for the most frequently reported contributing factors, and legal problems, if they are occupation related, add to the risk. While mental illness is marginally higher to the same among physicians, the acute event is rarely a mental health symptom, and physicians more rarely than the general public, have therapeutic substances detected in their bloodstreams. Physicians disproportionately die on the first attempt, be they male or female, young or old, and few give any concrete warning sign. Concerningly, factors that we have historically considered to be protective appear to be less reassuring in physicians at risk of death by suicide. Most physicians who die by suicide are married, they're involved with their families, they have a religious tradition, and they are working full-time. In some recent studies looking at ICU admissions among physicians who attempted suicide but survived, 21 of the 22 worked their regular duties on the day preceding their deaths by suicide. There also appears to be little overlap with impaired providers, though the interventions that impaired providers get may in fact mitigate their risk. There's been considerable work looking at individual risk factors like coping style. Individuals who are rigid, self-reliant, and have strong identities as physicians first tend to be at more risk for failed coping, be that evidenced by substance use, depressive symptoms, burnout, performance problems, or death by suicide. A number of programs examining individual risk factors focus on things like flexibility, maintaining relationships outside medicine, being in situations in which one is only accountable for an outcome to the extent that one is in control, and having a sense of identity that is greater than one's job. Other programs focus on burnout. But does happiness or feeling burned out map to death by suicide? Not so much, as it turns out. It's probably a bit more complicated than that. For example, surgeons are the least happy, the most burned out, and have lower rates of death by suicide than other specialties. While dermatologists are generally a happy, active lot with low burnout, but their suicide frequency is about the same. Psychiatrists have low burnout. We're not so very active. We have higher rates of things like heart disease than other specialties. And we also have high rates of death by suicide compared to other specialties. Even looking at this, the picture is complicated. While the rate at which surgeons die by suicide is less than other physicians, the rate of suicidal ideation, or thinking about suicide, is 1 in 16, which is on the high side in the specialty reports, and only 26% of those who experienced suicidal ideation actually sought help. In that study, depression and burnout were statistically associated with suicidal ideation, but not necessarily with death by suicide, which is an interesting disconnect that leads me to believe that treatable illness may be part of the story. When we look at studies examining symptoms of depression and burnout in physicians, we find very high rates of symptomatology, and a fraction of that population seeks treatment. When illness is present among people with suicidal ideation and suicide attempts in physicians, depression is the most commonly observed illness. So, what's going on here? While there are many possible pathways to suicide in physicians, the question is, why do distressed physicians who die by suicide generally not seek assistance? And among those who do, why don't they comply with recommendations? Given our knowledge about distress and the access to services that we would appear to have, what in the heck is going on? I argue here that to some extent, a focus on individual risk factors has been a distraction from the greater issues involved with the kind of self-stigma that is inconsistent with help-seeking behavior and treatment compliance once help is sought. A fair bit of that self-stigma comes from internalized ethical and professional norms that emphasize self-sacrifice, constant presence, and strength or invincibility. Interestingly, as people become distressed, be they depressed or distressed, this is a greater perceived barrier. When this gets combined with a more than trivial element of healthism in our society, the net result is that any illness or diagnosis is a weakness, not a trait. As a group of professionals, we overwork and we fear disclosure of foibles, in part because we are taught that we cannot be strong for the people who need us if we are not strong for ourselves. I believe that this emphasis on work and on personal value being attributable to work performance is firmly rooted in our professional ethics and in the regulation of the practice of medicine. Professionals are individuals with a specialized skill set of value to society. Acquiring this skill set often requires extensive periods of training and testing of competence. Professionals tend to enjoy great autonomy in their work, but this carries with it an expectation for self-regulation. Codes of professional ethics and conduct represent that self-regulation. Ethical codes are generally, however, not enforceable or only minimally enforceable. At some level, ethical codes call us to strive for ideals, while law and regulation set a minimum for behavior below which sanction or punishment occurs. Ethical complaints tend to be handled within relevant professional societies, while regulation involves the acts of agencies in stopping behavior that falls below accepted standards. Law is then good at punishing bad behavior, while ethics calls us to behave in the ways that we should. Medicine has been deemed to have largely failed in self-regulation regarding physician conduct and ensuring patient safety, with physician groups being referred to as good old boy networks. Medicine is also becoming an increasingly complicated endeavor, so there has been a rise in the regulation of the profession. Unlike ethical codes, regulation sets minimums for behavior and provides a mechanism for punishment. We would like to believe that regulation brings with it consistency, but such is not the case. The language is vague, and agencies have great leeway in how they interpret and enforce regulation. This variation, coupled with an amazing lack of transparency, contribute to both faulty rules and urban legend about rules, and this urban legend resists any education. There are many levels of regulation in medicine that impact professional behavior. States set standards for licensure. Credentialing bodies set standards for permission to practice in certain settings. Insurers then interact with physicians as both providers and recipients of services. Malpractice insurance protects a provider from liability related to the practice of his or her profession. Disability insurance protects a provider from income consequences of illness or incapacity. None of these levels of regulation are standardized or predictable in any meaningful way. They ask about illness in different ways, and they respond to reports by physicians in different ways. Specialty organizations, as national organizations, have done a better job being consistent, but to some extent have joined the patient safety movement and become less relevant to the professional lives of physicians in so doing. The ethical codes of the AMA and others emphasize duty and obligation in a way that is similar to regulation, though this does appear to be slowly changing. I don't know if you have seen the 2016 draft of the AMA ethics guideline, but there is a physician wellness section now that represents, I think, a significant move in the right direction. I'm wholly convinced that fixing this should not be hard. It doesn't seem a stretch to me to standardize questions about emotional and physical health asked by licensure boards and reflect those standards in credentialing and insurance. When you do that, it then flows pretty easily that you could standardize the consequences or the procedures that follow the reporting of these conditions to these agencies. And let's, for a change, acknowledge that the Americans with Disabilities Act did happen. It's been with us for a while now. And yet, I've practiced in 4 states. It's only been in one state that I have been asked about disability related to symptomatology as opposed to any prior diagnosis. Why is that? I get asked if I've ever been diagnosed with, considered for, or referred for mental health evaluation, but not asked whether I've ever had a brain tumor or not. What does that say about the way in which we conceptualize these conditions? Once we go through and begin to regulate more consistently, I suspect we then don't have to worry about people lying or not disclosing. Surely a safe practitioner in North Carolina and a safe practitioner in Texas and a safe practitioner in Indiana would meet similar guidelines. Yet the questions are very different. Some states restrain their questioning to a particular time period, like the last few years. Some constrain their questions to disability as opposed to diagnosis. And for some, it is wide open. And if they don't get you on the licensure application, surely they then get you on the credentialing application or on the medical malpractice insurance application. So in fact, when I moved to the IU health system, some of the most intrusive questions about my health actually came from the IU Health Risk Retention Group, which is our med-mal carrier. And oh, by the way, in every state in which I have applied, I have had to sign a blanket access for release of my lifetime's medical records, just in the event they found something. That doesn't mean anybody went to get them. But think about the impact on that for someone applying to practice with no idea what answering truthfully will look like on the other side, and no assurance that the monitoring will ever end. I'll give you an example. When I was a much younger provider and was working with a medical licensing board that will remain unnamed at the moment, I was evaluating a physician for major depressive disorder. Never hospitalized, never missed a day of work, but in a lot of pain. The physician reported this to the medical board, honest reporting. They asked about lifetime. She had a diagnosis. We were off to the races. And I was notified as her provider that she had been placed under review. And she was going to be monitored through the physician health program. And her monitoring consisted of her being called for random urine drug screens. I said, pardon me? They said, yeah, you know, she's going to get a number and she has to do this and do that. I said, beg your pardon? I said, she doesn't have a substance use disorder. Oh, we know. Okay. None of the medicines I'm prescribing are going to show up on a drug screen. And they said, we know. And I said, so isn't it more important that she takes her medication and comes to her appointments? Yeah, I thought we were on a roll here. Um, well, yeah, we think so, but we don't have a protocol for that. So for 2 years, this physician was on a random dial and dropped 4 random urines. For what? 10 minutes late for one of them, and got a letter saying, if it happens again, we will revoke your license. It doesn't take too many of those stories to build the urban legend that you can't be sick, and if you are, you can't say. When that then feeds into a culture that we already have of invincibility, bad things can happen. At the systems level, for heaven's sake, let's employ enough physicians. Physicians do have scarce skill sets, that's true. We can be expensive, that's true. But we have a constant service expectation in our industry. We have a 24-hour news cycle, if you will. We didn't have a 24-hour news cycle when you alone had responsibility for your patients 24/7. Other countries have set duty hours limits. We know from To Err is Human and other reports that fatigue is a major factor in fill in the blank: burnout, error, depression, substance abuse. And let's be consistent with pay and expectations. The rise of the employed physician is this generation's rally cry, right? And while I think in some ways that is a misnomer, because the problem of physician death by suicide has been with us much longer than that, I do believe that the notion of the physician overvaluing their role as breadwinner is a big part of what drives some of our difficulties in being away, be it for treatment or for downtime. Systems often don't expect physicians to actually go away, and physicians collude with that and don't ask for time off. A lot of the reason they do that is because they don't want to burden other providers. Because there are not enough of us to start with, and nobody has a plan for what it looks like when one of us is gone. I also think that systems should encourage physicians to get involved in physician advocacy groups, particularly if you could get away to go to the meeting, right? We don't need systems to love us. We know they don't. We need opportunities to get mentorship and support from somewhere. And that will typically come from other groups of physicians in some form. In talking with systems and medical boards and other things, they sometimes say to me, what do you think it's going to take? And I think in large part, it is going to take some mechanism of groups of physicians to impact this. And in fact, for their warts, physician advocacy groups are the only mechanism we have for this. Please don't interpret any of this as my saying we should ignore individual risk factors. I am so not saying that. Information, stigma busting, wellness education, it's all good. It will impact some levels of the problem. we as individuals may choose to sprint part of the time, right? If you're in surgical training or procedure-based training, you need procedures. You need patients with that problem. You need to develop expertise. So you may, in fact, make some choices that are not very healthy to gain those skills, but have a programmed period of time after which you step back and look at what you've gotten, what you've given up, and how you're going to rework the next place in your career. Too often we sprint, we build a system around our sprinting, and then we can't stop. And that's when trouble tends to happen. So yes, address individual risk factors, but please stop blaming the individual. And I do think we have crossed that threshold. A healthy physician is a physician with managed diagnoses, not a physician who refuses to admit they have one. In this era of medical care, with early diagnosis and treatments that are tolerable with regard to side effect, a diagnosis simply does not mean the same thing that it did in 1920 some odd, when many of these medical board regulations were written. And while I dig resilience, there is some stuff you just shouldn't be resilient about. There are some situations that are intolerable, and no amount of deep breathing, listening to classical music, or going to the art show is going to change that. Is it time to rethink the ought, what physicians ought to be? We sometimes think about ethics as the oughts and laws as the whats. So I come back here to this theme. Can we value a well-rested physician over an ever-present one? Are we more similar than different among our specialties in what we need as professionals? Given the complexity of medicine, do we work better in teams than we do alone? Do we in fact need teams to provide 24/7? And I would submit we do. While we've gotten pretty good at policing medicine, do we need to revisit the equally placed ethical ideas about supporting each other? You're expected, yea, verily, you even have a duty to report the impaired or dangerous physician, but I think you have an equal duty to support each other. Not all distress is mental illness, right? And I'm a shrink and I can say that. Sometimes life just stinks, and it stinks less if you're not alone in it. There's a bunch of crap out there that drugs don't fix. There ain't no shortcuts in this life. And so this notion of identifying distress and seeking care will lie with the individual and only secondarily with colleagues. Some schools have, in fact, core competencies in self-awareness that go along with core competencies and knowledge and other things for medical schools, but the vast majority don't. When we don't have that trait in ourselves, it's also very difficult to identify distress in others, be they patients or our colleagues. You know why in studies of doctors we don't look for distress in colleagues? What do you think the studies say? No takers? Yes! Suzanne makes a good point. We don't, that's number 3 in the family feud. What else? So then let me repeat for the recording. We don't want to acknowledge it in ourselves, and we can kind of stay away from it. Yep. And you make another good point. Number 1's getting close. We don't know how to respond. So we don't have, in fact, in most settings, confidential access to services. There are states that have fixed this. Anybody from Colorado? No? Colorado has what I consider the coolest model program in the country right now. And the Colorado Physicians Health Program is separated from the medical board. Once a physician comes voluntarily to that program with just about any life problem, because they have litigation support and all kinds of stuff going on, they get a number. And they get a number because services are confidential. And the Colorado Physician Health Program negotiated this arrangement with the medical board. And as I understood it, it was kind of a hard-fought battle. The Colorado Med-Mal carriers, in fact, provide litigation support for people as soon as they are named in a complaint or Med-Mal matter. And in fact, what the data from Colorado shows is that as soon as they opened the door to confidential self-initiated treatment, the number of complaints went to virtually nada. What that tends to say to me is that if you give people an outlet to safely seek care, they don't wait until they get complained about. If you have a mechanism by which people can refer colleagues that is in fact safe to them and their colleague, they will use it. Again, doesn't seem that hard. But equating a sick doctor with being a bad doctor is not going to get anybody better. Anybody want to take a guess? So we don't know what to do. We don't want to acknowledge it in ourselves. Anybody guess what number 3 was? Why we don't? No? There's a huge amount of that, of not expecting them to have a problem, and we fear retaliation, interestingly. Comes up again in the studies. So what I'd like to do is stop there because I would love to hear your questions and respond to any feedback that you might have.
So Tracy, if we're able to somehow identify a physician at risk of suicidal behavior, how successful are psychiatric professionals at, once they've identified the person, at lowering the odds that they'll carry out an act? In other words, do we have successful therapies to prevent suicide once we've identified a person at risk?
Paul asks a great question, and that has to do with what we do once we've done the identification. The data is mixed. In some studies of physicians, as many as 60% of physicians had been in or were in mental health treatment at the times of their deaths. That's kind of a sobering number, isn't it? I think what that speaks to is that treatable mental illness is only part of the problem, and that there is this critter of distress and life event that in fact will drive the sense that there is no other way out. Litigation support appears to have been a major inroad in some systems. And the difficulty, of course, is that physician death by suicide is relatively rare. So how do you identify that which you prevent? Because physicians disproportionately die on the first attempt. So to that extent, the emphasis on consistency and regulation, in the emphasis on changing the internal representation for what distress means for physicians, the notion of developing flexibility and controlling these other risk factors through wellness programs is kind of where we are. Will that decrease death by suicide? The short answer is we don't know. What I've learned in this research and in other suicide research that I've done is that we simply don't understand the phenomenon of suicide very well. What I will argue with you, to you, is, however, that as we improve the practice of medicine, it is a win-win for patients and for us. The other body of data that gives me some hope that addressing regulation and making access to confidential peer services and confidential treatment services both work is the data by the American Bar Association. So the American Bar Association did a white paper series several years ago because they had one of the highest, they were second to us still, of course, rates of death by suicide. They identified some risk factors, particularly among judges and other people who were isolated. And they, in fact, began devising a number of these wellness programs that are now coming into medicine. And they have seen a decreased risk of suicide. How that trickles down to the individual when you're studying a rare phenomenon is a little bit unclear.
Just wondered about implications related to trauma that some physicians are exposed to. Is that kind of looked at too as a contributory factor towards suicide?
Absolutely. When we look at particularly the specialty-specific data, one of the things that they are finding time and again is that very high exposure to trauma in the line of work and a pre-existing history of traumatic life experience can combine in a way that potentiates risk of death. That data has not been well replicated, but it's certainly there. So people who are on the front lines of patient care are said to be at somewhat greater risk than people who are in consultative roles and that kind of thing. Trauma surgeons, those kinds of things, sure. No? Well, speaking of specialty-specific factors, it also appears, in addition to whether folks are on the front line or not, whether the specialty is regarded as in the mainstream of medicine makes a difference. So in fact, specialties like like psychiatry, like research-based medicine, that are sometimes deemed outside the traditional practice of biomedical practice, have higher rates as well. And whether that's because of self-stigma or whether that really is because of a sort of pecking order in medicine is wholly unclear.
Tracy, what about medical schools? I mean, they're not doctors yet, but they're doctors in training. What is can be done, is on the forefront of being done around the medical school community and training physicians?
That's a great question. So what we know about physician death by suicide generally is that it's a bimodal distribution. So those entering the profession and those approaching their retirement years are at greatest risk. Medical student suicide is somewhat more difficult to follow in, for instance, the autopsy studies and some of those things, because under occupation it will say student, but nothing else. But what many medical schools have started doing is looking at retooling their curricula so that some of these values that I was talking about get operationalized very early on. So in my day, as we approached the clinical years, we went from a 9-month schedule or a 10-month schedule to a 12-month schedule pretty quickly. I think my last summer break ever was my first year in medical school. And what schools are beginning to do is to build in more breaks that allow time for consolidation of experience and some downtime and those sorts of things. Schools are also going to pass-fail systems on the basis that there's a minimum level of competence that someone needs to get into residency and to be a physician, but that the levels above that are not really too important in differentiating it. I have some concern about that philosophy. I like it intuitively. It's egalitarian. It feels good to me. But I think what's going to happen is that it is going to increase the stress on single high-stakes exams, because the transcript will, in fact, begin not giving actionable information to residency training and those sorts of things. So I've got some concern about how we've done the whole pass-fail thing. Another thing schools are doing that I think is really cool is they're doing some mentorship programs, and they are doing some programs that look at a sort of facilitated mentorship. The problem with this in the early analysis is that the faculty they are going to be mentors are themselves burned out and say things like, no, you cannot take sertraline because you'll have to tell the medical board. And say things like, yes, you really do have to be. So, you know, we're in a funky situation there in which our role models may not be in very good shape to model what we would most like. Other things that are happening are explorations of interest allowed earlier in the curriculum, so less of a lockstep to the curriculum, but in fact some time in which students can explore interests. And integrated curriculums are much more common. So you don't use surgery just on surgery and OBGYN just on OBGYN, but in fact there is some integration across medical specialties from the time of training. And one of the things people are hoping is that that will foster a sense of identity as a physician before identity as a specialist. In other things, there is a big move toward wellness groups. There is a big move toward incorporation of arts education in aspects of medical school. and we'll kind of see where that goes. That piece of it, I think, is a little dicey. With regard to, unless, however, you're going to make medical school 10 years, and then it's fine to do that. In the residency years, we see duty hours limitations, and that has, in fact, resulted in some decreased reported distress among trainees, though we have a funky situation in which trainees that need a lot of on time are in fact perhaps misrepresenting their hours. So we don't entirely know what that looks like. But certainly that notion of limited training hours, we're doing more distress monitoring than we've ever done. That's now part of what the residency training program has to offer. And my concern is, in fact, if we don't change the practice situation to which these young scholars and young practitioners then come, the only thing we've really done is to move the train a little bit further down the tracks. I'm not sure we've stopped anyone from getting hit by it. And that's one of the reasons I wrote the papers that I've written about some of these issues about looking at regulation and standards for practicing physicians. We also need to teach people how to retire. We just do. Yes.
Hi, Tracy. This was awesome. I just actually had a question I was curious about. As medical education graduates continue to have more and more student debt when they begin practicing, is there any literature, any evidence or data that discusses that being a risk factor for bad outcomes like these?
Sure. Brian's question is about debt load and risk. And one of the things that we see some schools doing from fairly early on, though this is not common, is beginning to introduce more dual degree or multi-degree curricula so that the person potentially diversifies into a job market that is not that of a practitioner or a researcher, right? Right now, at present, you come through and the expectation is you will do one of the two. And in fact, some schools are looking at MD MPHs, MD MHAs, MD JDs, a variety of MD PhDs, because healthcare is a big organism and there are lots of necessary jobs. What people then begin to hypothesize is that you will see an expanded job market. One of the things that has happened in medical schools is in some ways not dissimilar from what's happened in law schools. And that is that we have increased the number of medical school slots, but the number of residency slots have not increased. So what happens when these students with this debt burden are now faced with the potential that they will not be able to practice in either of those traditional pathways? So to begin to kind of defuse that, schools have started looking at what kind of job they're doing, teaching their students to value their doctoral level education and view that as opening their horizons rather than closing them down. But there's no doubt that debt burden also influences people to make moonlighting decisions and other things that may well not be in their best interest.
Okay. Hi. Can you speak briefly on, as all new physicians go out, start working, can you speak on those physicians that may get out there, want to work the extra hours, get into a practice, and then find out after working so many hours that a partner leaves and they have to work even more hours? longer nights, no rest, depression, stress, anything that may set in, and doing this for a hospital corporation. And then when the wheels finally fall off 6, 12 months, 18 months later, and the physician is reprimanded for anything, it could be as mild as an argument with somebody, it could be as severe as substance abuse or anything like that. Can you tell us if there's any legal recourse for an individual like that being in an environment where they didn't have the resources, the other physicians, locum tenens, anybody to come in and help? And is there anything that physician can do if that situation were to happen?
It's a great question, and very few of the underemployed, overcommitted situations that I was talking about before were planned in advance. Sometimes they are, but it's more common that because we don't bring enough people in to do the workload to begin with, that in fact, when those losses happen, the workload gets greater on the person that's left. And the short answer is, from a legal perspective, I have to say what any good attorney would say, even though I'm not an attorney or a legal scholar or a JD, and that is, it depends, right? If you're talking about an employer, it's going to depend on terms and conditions of employment and that sort of thing. The way the marketplace has historically responded to it is simply by saying, you're a professional, you have choices. If you find a position unacceptable, you're free to leave it. I'm not saying that's a good answer, simply that has historically been part of the way the profession has responded. In terms of sort of what you can do or what I've seen physicians do, for people who are in private practice, who at least have some control over their front door and their back door, downsizing practices, bringing in mentors to help them, or practice consultants to help them move patients into other practices or get them referred or get them terminated from the practice. That kind of practice simplification is one thing. That issue also comes up as people try and slow down as retirement approaches. So how do you match the work you're doing with your abilities and your reserve at the time? And I saw one more hand. Yes?
I was just going to ask, you talked about the efforts in Colorado. Can you speak about the efforts in regards to regulation here
In Indiana, and I'll repeat the question. The question is about initiatives in Indiana. A couple of things have come up. We have the Indiana State Medical Association that provides some services. Unfortunately, they are dramatically underfunded even to discharge their patient protection initiative. So they are not, at this point, prepared to expand, and I'm not aware of any grants or anything forthcoming that would use that mechanism. The Indiana State Psychiatric has just formed a physician wellness committee that is in the process of getting up and running and prepared to, I believe, engage in some negotiations with ISMA. Indiana is interesting in that it does not provide access to confidential services. It has a very, I think, high requirement for physicians to report to each other and has very few resources to deal with that. But I've not had the experience that the licensure applications or other things were particularly onerous compared to other states. If anything, I think Indiana suffers from the same kind of a lack of transparency that the other boards do, what would it hurt anybody to say, if you report a medical condition or a mental health condition, this is what's going to happen, right? I mean, what would that cost anybody? But Candace Backer at the ISMA has been very involved with the Federation of Physician Health Programs, and she is a huge advocate for trying to find services for people. The issue for Indiana and mental health services is that we are sorely understaffed. And there are now a few different physician groups trying to collect resources, and that is names of practices that would be willing to see physicians on relatively short notice. And there are probably 7 of those up and running, and I can get you some more specifics on that if you like.